Good afternoon. If we can all please take our seats. Thank you.
Good afternoon. Good afternoon. It's good to see you. I've seen so many of you earlier today as we had our strategic planning, another part of that at a different location. So we're all kind of rushing over here to get started. But I just wanted to say thank you for being there, those of you who could make it. And we're happy to be here and continue our work. And I'm here with my co-chairs who I'll allow to introduce themselves, say hello, and turn it over to Senator Marr.
Thank you. It's great to be here back in this room. Thank you so much for remembering. I asked for it. I really appreciate that. It's nice to be able to see people's faces. So we have a lot to do. I'm looking forward to hearing from innovations at UConn today. That's going to be great. So I don't want to talk too long. I will pass it over to Claudio.
Thank you. Welcome, everyone. Excited to dig in. It was great to have lunch with you all and do some brainstorming around our shared purpose and vision going into our strategic planning, and a lot of initial review of the recommendations today, which should be a good discussion from everyone. And yeah, look forward to just getting started. Thank you.
All right. Good afternoon, everybody. Erica Nowakowski with the Tau Youth Justice Institute. First, some housekeeping. We do need to do an acceptance of the September TCB monthly meetings. Were there any suggested revisions or edits? Seeing none, can I request for a call for acceptance of the meetings?
So moved.
Okay. A vote for approval?
Aye.
Aye. Okay. Thank you. No abstains? Okay. Thank you so much, everybody. Before we get started into the and give the floor to Innovation Institute at UConn School of Social Work. First, I want to say to everybody, just kind of do a little level setting. I want to first thank everybody who's been part of responding to our multiple surveys and or providing feedback in the various work groups that we have established. Just as a reminder, we have currently 2 work groups. We have the infrastructure work group as well as the services work group. They meet virtually once a month. And through those work groups, we've been, you'll get to hear today some information about a first glimpse of some recommendations that may be coming to you for possible legislative recommendations. Again, these are drafts. This is just in development phase, and we intentionally sent out the draft language using the review feature because that's what it is. It is still in development. It is not finalized. The next few months, we want to hear from you all. We want to hear from you as to this recommendations package. Please feel free to attend our work groups, which are, if you need the meeting scheduled for our work groups, please contact myself or Israeli, and we can give you the virtual link as well as the dates and times for when they meet. We will be having meetings November, December, and so forth. Secondly, I also want to thank you all for completing, or many of you completed the mission statement survey that we had based off of the feedback that we've collected from the different surveys you have all completed, as well as feedback from focus groups and times that we've gotten together to do some strategic planning. We collected your thoughts, your recommendations, and constructed, with your support and your assistance, 2 mission statements. We then asked you all to vote on which mission statement you would like this to live in the committee of the Children's Behavioral Health, the Transforming Children's Behavioral Health Policy and Planning Committee. And based off of that, I'm going to if you don't mind, I'm going to give Israeli the floor to present some of the data around how many votes we got.
Good afternoon, everyone. So in total, we received about 36 responses, and that's not counting duplicative responses that we received. But out of the 36, 28 were from voting members. So the chart that you see on the PowerPoint is for TCB committee members. So option 2 was the preferred mission statement at 20 votes from TCB committee members, and option 1 received 8 votes from TCB committee members.
So at this moment, your option 2 is your current draft, and I'm saying draft mission statement because this doesn't mean it's the end all be all. We do have later on after in the presentation, we have a timeline to share with you all as we're starting to compile the larger document that reflects your strategic plan. There's still opportunity to give us feedback and thoughts around this mission statement too. You all are the ones who are making this come to life. You all are the ones who are operationalizing this. So you need to feel comfortable with this mission statement. And so I would like to kind of put on the spot our chairs in the sense of, do you want us to keep this survey open? This is how you see how many votes you have received. Again, this is probably our third attempt, right? This is our third attempt at trying to collect some votes on these 2 mission statements. We can keep it open. We can close it and leave it, move with this mission statement option 2 and see if it needs to be further revised and refined. But I would love to hear from the chairs and anybody else in the committee.
I think so. Thank you so much, Erica. In so much that we've had this open and for quite some time now, and everyone has had the opportunity to participate, I think my co-chairs also agree that we should close it at this time and just accept this and move on with recommendation number 2. Thank you.
Thank you, everybody. Again, we will start to insert this option 2 into some of the draft documents of the strategic plan, which you will shortly start to see getting chapters. I'm not going to inundate you with the full document. I'm going to start sending you chapters of the strategic plan as we are collecting your feedback on purpose statements, objectives, strategies, data that we need to collect to ensure that we measure our success. So you'll start to see sections of those parts of the strategic plan for a full document delivery to you all sometime in January for then a vote of adopting the finalized strategic plan in February. Okay. All right. Any comments, any feedback from anybody around the mission statement or the process? All right, so now I believe our Innovation Center partners are on Zoom, and I see Michelle Sable. Are you there?
Right here.
Thank you so much, Michelle. And I also want to say, thank you to Michelle, Deborah, and Jill and Lena. They have been amazing thought partners in this process and have been attending the work groups on a regular basis and providing their content expertise and advice. So really excited to hear their presentation today. And so, Michelle, I'm going to give you the floor.
Sure. And am I sharing the PowerPoint, Erica, or maybe even better, one of my people?
Yep, we can share the screen.
Maybe not me, because that makes me do a lot of things at the same time.
Okay. Do you want Deborah?
I think I think we got it, Erica. Thank you. So first off, let me say, I wish we could have been there in person with you. I wish we could have participated in lunch and planning, and we're so grateful to always be included in these meetings. I feel like people have built this presentation up, so I'm really hopeful that this is what you guys need it to be. We are responding to the ask of going through a little bit of who we are again, and then what our scope is with TCB, and to answer any questions. And then we also weighed in a bit on on some of the suggested language for the potential legislation. So we'll be here through the whole conversation as well. But I'm Michelle Zabel. I'm Executive Director at Innovations Institute, and I'm founding director. So I have kind of a vision and a long-standing experience with this organization and the many people that have been with me through building it. So for those of you who are still trying to figure out who we are or what we really do, I'll back up just a little bit, tell a little bit more of our story than I did before when we've presented. So we started back in 2005 was our first contract that built us. We were originally organized as a Center of Excellence for Maryland with our Maryland State Children's Cabinet. And for a number of years, we were super deep in that state. And so I always tell people, you know, we come to the table in any of the TA or research or support that we do, really understanding how difficult it is to move state systems and how behind closed doors, people are working really, really hard to make the lives of children and families better. But there's politics and perceptions and other things that get in the way. And so I think what makes us a unique implementation and TA center in the country is that we are just very operational. So when you get stuck with us, you're going to meet a Deborah Harburger who might rewrite your policy statements for the legislature, might write a Medicaid state plan. If you meet Jill, she's going to ask why we need to gather that data because it needs to be useful, or why would we do it? So, you know, throughout our kind of three-legged stool of being organized, which is our research, evaluation, and CQI folks, our small but mighty policy and finance unit, or our much larger systems design and workforce development group. That's how we engage with states. On any given day, we are working in about 30 states across the country, across the year, and that has stood firm since, you know, probably for the last 10 years. So we have at this point in time worked in every state and in every territory in the country, and have relationships with a number of the tribal nations in our country as well. To back up a minute, so we started as a state center of excellence, much like CHDI and many of the infrastructures that you already have here in the state of Connecticut. And then it was about 6 years in. So I give us over 12 years credit of working nationally. We were asked by federal CMS to step in to doing technical assistance across states who were engaged in the PRTF demonstration waiver, which was our country's effort to really start to think about deinstitutionalizing children. Obviously, that has been an ongoing conversation in our field for a number of years, but that was one of the first times CMS actually invested in thinking about redirecting their funds, reorganizing how service looked, and making sure that at a CMS level, the states were getting kind of guidance and opportunity to do things differently. And so we were lucky enough to be asked by them to step in and help those states, along with our own, to design and create opportunity that way. So just, you know, as an example, just to give you a little depth, so some of you may know the National Wraparound Implementation Center. That's housed at Innovations Institute. There's a number of quality improvement centers funded at the federal level across the Children's Bureau and SAMHSA that we also have housed at Innovations. OJJDP is another national center that we're involved in. And then we tend to sit across multiple national centers that maybe we don't run, like the National Council and the efforts around CCBHCs across the country, will sit as the children's experts in both of the TA centers helping stand up CCBHCs across the country. And kind of the list goes on. So that's one way that we engage. Another way that is a regular ask of us is when states are being sued and there's a Department of Justice settlement agreement, and DOJ and the state will come and ask us to be subject matter experts on the settlement agreement. We don't get on the wrong side of states. We don't testify against states. That is just not something we will ever do because we know state government is trying. But we will help on the settlement side to actually walk people through how to improve systems and so on. So you can kind of see a theme of how we try and engage in helping systems, whether we get in there around models that we've developed, like wraparound, or there's a call for a fiscal review or a Medicaid state plan review or so on. The list goes on. That's how we would best be partnered with states. So we were super excited when we first got here to Connecticut to be asked to be part of a partnership with TAO. And it's been a great experience to date, and we're excited to help you guys in the efforts to build up and continue to improve the Connecticut system. The next slide is me doing a pitch. So put up with me for a minute. We've said this, and I'm going to say it until we host it. We are hosting the 2025 Training Institutes. For anybody who has not gone to the Training Institutes, this is our country's 40-year-old conference that is about children, youth, young adults, and their families who have to access systems, public systems. And so this was a conference that you may know as having been traditionally hosted by Georgetown University. It was back in 2017 that we were asked to step in, and Georgetown helped us pick that up. Some of the wonderful leadership at Georgetown still has their fingers in this training institute, helping us run it. So we ran our first one in 2018. COVID hit, so we went virtual, and now we're doing our first post-live conference in National Harbor in Maryland in July of 2025. We are super excited. The call for proposals just closed. If it's an indicator of robust attendance and a good time for people to come and see colleagues from across the country, this is the largest response for a call to proposals the Training Institutes have had in its 40 years. So this is a pent up opportunity, and it is all kids all the time. So not all of you know me, but a lot of times I have to sit in rooms with a bunch of people who are really very focused on adult services. And I'm the one there going, hey, don't forget about kids. And so I had an opportunity when we gathered CCBHCs this summer to be in a room of all kids people, and it was just good for the soul. And so not only am I pitching the Training Institutes to come and to learn and to hear from your peers, states on what they're doing about particular issues around service array development, financing, CQI processes, all of it, but it's just really good to be in a room with a bunch of people who prioritize children, youth, young adults, and their families. So I encourage you all, please come, please disseminate this, please make this a convening that we as a country can come together and learn from each other around. And it really is the peer learning that matters at the Training Institutes. The next thing I do want to point out to you is that innovations amongst all the other things we have a fairly robust learning management system. And many times as I'm listening to the questions that are coming out of the work groups or the TCB as a whole, I keep thinking to myself, well, we have a short module on that, or we have animated shorts on that. So I just want to pull up for you again this learning management system. Right now, we're tipping towards about 17,000 users nationwide that have logged in and kind of annually use the site about 85,000 times a year. So I just asked my people for these stats. So these are right on top stats. And so I would just encourage you to take a look at it. And the next slide will show you some of the modules that I think would be worth people stopping. They're not long. They come straight out of what we in behavioral health have seen as kind of our textbook or our toolkit, which is Building Systems of Care, a primer. It was written by my mentor and dear friend, recently deceased, Sheila Pyries. Sheila was really a formidable force in building these online modules. And so whether you look at the book she wrote or the toolkit she wrote, or you go on to the modules and do them a lot shorter, so I'd encourage the modules. These come right at a lot of the questions we keep getting asked in Connecticut, and I think it would just be worth people finding the time. I would also say to all the executives in the room that if you have staffing training needs that we've seen tons of agencies across the country pick these up, and at least number one, introduction to system of care, use in their onboarding processes. So these are just good baseliners for people to have good senses of language and what the definitions mean, and a good touch base if you get a little lost along the way as we're doing system building and holding ourselves accountable to improving outcomes for kids. So with that, I think, unless my folks feel like I left something out, I want to hand this over to Deborah first, I believe, to talk about our actual work with the TCB and on behalf of your work groups.
Yeah, great, thanks. Hi, I've met many of you or been in work groups with many of you. I'm Deborah Harberger, and I'm Director of Policy and Financing at Innovations and Assistant Extension Professor at the School of Social Work. And we wanted to frame this. We've been in these rooms, a lot of you we've really spent time with. So hopefully some of this seems familiar, but we wanted to first say that our approach is really based on looking at national best practices, evidence-informed approaches, and really hearing from individuals with lived expertise. And then when we go through, because there's various places where you'll see we're going to make recommendations. And so we really want to highlight the fact that we are balancing these sort of national findings and evidence and research, but we're balancing it with what you all tell us is effective, what you raise up as reports that are seminal reports, recommendations that have been made time and again, things that have worked and things that haven't worked. And it's really a priority for us that we integrate that information. And so we've been asking for resources. People have been sharing them. We're going to keep asking for that in each of the areas where we're making recommendations for consideration. We are going to be incorporating both that national lens as well as what we find in Connecticut from our own research and from what we've learned, as well as what you all share with us. And at the end of the day, our goal is to make sure that all the recommendations that we provide for consideration are really grounded in systems of care and those values, right? That they're individualized, that they're family-driven, youth-centered, that they are actionable, that they're specific, and they're sustainable. So our goal is to make sure that we're not making recommendations that stay at the 30,000-foot level or even 20,000-foot level, right? But that there's something that can be walked through to be implemented, and that we're thinking about sequencing of activities and what needs to come first based on priorities, based on sort of the natural flow of things, based on what we know families and young people have told us is effective, what the providers have been sharing is a most pressing need. And so we're really framing that based on all of our experience working with state and local government, with providers, with families. And we keep going back to them and we keep saying, what are you hearing? What's working for you? So that's sort of our frame in that. So there's a few things that we've talked about this before, and I think when Erica and her team asked us to present, it was an opportunity for us to really remind folks of what we had talked about in terms of these particular activities tied to the legislation and provide you an update, not so much on the work itself, but a little bit more on the deliverable dates and how we're sequencing all of that with all the other work that the work groups are doing. So the governance task hasn't changed. Lena and I came to the strategic planning meeting in June. We've been part of these work groups, so this is not new, right? We were tasked to review and analyze interagency structures, governance, and oversight mechanisms related to kids' behavioral health in Connecticut. So we're incorporating our review of national best practices, local approaches, and the goal is really what recommendations can we make to support TCB's goals around transparency and accountability for those state-funded children's behavioral health services, and for governance structures. So when we speak about governance, and you all may have talked about this earlier today, but we're really talking about population accountability, the entity that has responsibility, accountability, authority, legitimacy for for that population. They may or may not be the people who are involved systems management day-to-day activities. They are not necessarily the people who are advising or providing sort of external oversight and checks and balances, but really those entities that are ultimately where the buck stops, right? And who has that legitimacy and authority. And typically, as we talked about in June, that's really inside of the executive branch of government, with lots of other kinds of oversight and advisory functions and engagement, meaningful, relevant, genuine engagement with legislators, with providers, with family members and young people and others. So this report, the timeline, we have shifted in communication with work groups, with the tri-chairs, with Erica and her team. So the draft report will go in mid-December to Tao Youth Justice Institute and the tri-chairs. We have a deadline for the final report to be completed at the end of April, and that was intentionally a long period of time to give folks time to read, review, give comment, give feedback, tell us what we missed, for us to make edits, adjustments, and have a final report. That report is not necessarily the report that you all take and just sort of package up and submit to the legislature, right? It's still our report at Innovations provided to you all based on what we found, but we wanted to reflect accurately what's going on in Connecticut, what your priorities are, what we've heard from you, and what's going on nationally. So there's a big long window there. If it's done sooner, great. But that is really why there's this gap, that time period, to give enough time for people to give meaningful input, recognizing legislative session will be occurring. The next task is one that was not part of our tasks if you had asked us this time last year, but it's come up, and to do a financing desk review. And what we mean when we say that is taking a look at the various reports and documents that exist, the recent rate study, your Medicaid state plan, and any other really relevant documents specific to how kids' behavioral health services are publicly financed in Connecticut, with probably a heavy focus on Medicaid, and look at that. And so what we're asking is for folks to help share any other seminal documents, and we will come up with that list of which documents we're reviewing. You know, usually we review somewhere between 15 and 20. We did just complete one that had probably 60 or more. Lena, I think, right, that state was 60 or 70 we reviewed. But, you know, really a tight review of the state plan and other materials. And that by the end of March, we'd provide our draft financing desk review. When we say desk review, meaning that we're not doing a bunch of stakeholder interviews, and we're not going out and talking to people, and we're not doing a lot of administrative data review. We're really looking at these documents and these reports to say, okay, this review highlighted this challenge. And when we look at your state plan over here, this is what we see. And pulling those all together with a lens of the priorities of TCB in particular. And bring it back, and then get a final review back for folks to look at that will contain recommendations, priorities, things for consideration. Rate information may be part of it, really is usually like a piece of it, but it is not solely about rates. It's also about what services are being covered, how are they being covered, what's clear, what's not clear in the state plan, things like that. And then we know there have been children's behavioral health expenditure reports done in the past, sometimes known as fund maps or fiscal maps. So we agreed to provide an initial draft framework for what an updated behavioral health expenditure report would look like, could look like. We're not conducting it in this time period, but if TCB and Tao and the tri-chairs decide that it is a priority, you'll have the framework, whether it's us implementing it or someone else, to then go ahead and do that. And that takes a lot of data from state agencies in particular. It is a lift by agencies too, not just the people doing the report, to look at and to make decisions about things like what's a good time period, what services are we including and not including, which funders are we including and not including. And based on the desk review, that will help inform this report or the framework for a report to say, what are the priorities? And all of this goes to an aim of really sustainable financing for the services and supports that are most important to all of you, and helping to make sure that the investment is there in the home and community-based service array in particular, while ensuring that you have necessary capacity for acute care and residential where it is critically needed. So that's really the approach. That's what we're doing. Again, the governance isn't new, financing and the expenditures report is newer, depending on when you were part of a conversation with us. The deadlines have been adjusted and to align with all the other work coming. So I don't know if we have any questions on that, or we want to shift over to Jill to talk about the other tasks.
You can proceed to Jill,
Okay.
and then we'll open it up for questions at the end.
Okay, great. Thank you. Okay, so I'm going to turn over to my colleague Jill to talk about data infrastructure.
Thank you, Deborah. Hello, everybody. My name's Jill Farrell, and I'm a research scientist with Innovations. I'll be hubbing the next two tasks that I'll review here. The first is related to data infrastructure, data sharing, and continuous quality improvement. As part of this task, where the end result will be a report similar to what Deborah mentioned in the previous task, where there'll be a report with recommendations for us. Is within this report, we're assessing the data systems related to children's behavioral health in Connecticut. So what are the key systems? What's happening in terms of data sharing and data linking? And what processes are currently in place for CQI, quality improvement, quality assurance type efforts to make sure that the data is used to help assess the system, make sure things are going well and used for improvement purposes as well. There's a lot going on in Connecticut. So I think our intent is that this is going to be a kind of state of the state for all the efforts that have been going on in the last decade related to data, building out data systems, data integration, and QA processes. And then we'll also have a section that summarizes efforts happening in other states, best practices, innovative efforts related to data systems, QA, et cetera, use of that data for children's behavioral health. So, and highlighting systems and structures that Connecticut might want to look at as in terms of improving what's happening in this state. So our recommendations will revolve around where to bolster in these structures. And into this report, the draft will be pulled together for review by December, mid-December, so we can go through the same process in terms of review, where people get to make sure we're kind of covering everything, especially if this is a state of the state for data systems and structures, because there is so much going on. It's a nice opportunity to summarize it all so you can see where growth happens over time as well. And then the final report would be completed in April, as we get feedback for that process. Next slide. For the service array assessment, the intent here is also to develop a report. It's going to summarize our efforts that we're currently undertaking and planning to identify the Children's Behavioral Health Service Array in Connecticut, as well as what are the population needs, at least based on the data sources available to us, and taking those two sources of information to identify service gaps. The gaps will be, and I should say we're focusing on the publicly funded behavioral health services at this time, so through Medicaid, state funds, et cetera. The intent is to provide a baseline so that you have this what exists in Connecticut, and as you're building over time, there's kind of this anchoring of where the system is and where it's going. We'll provide recommendations in terms of filling those gaps based on local input, as well as what does a kind of quality service array look like based on efforts across the country. And to do this project, I should note that we're going to be surveying providers, and we currently have a subcommittee from the services work group who's working together to build out what this provider survey would look like, with a nod to that some of this data is being collected through state agencies or other systems. So we're identifying what data sources already exist and could be available to help us flesh out the service array, and then what needs to be explicitly asked to providers to help us understand the state of that service array. The report is on a little bit of a different timeline because we're in we're planning to implement this survey. So this would go out in January. As the data comes back, we'll be creating profiles summarizing the data we're getting from the service array provider survey, as well as the needs data that we're hoping to get from other sources to help kind of juxtapose the service array against the population. And then using that presentation to get local input and we'll ultimately identify our recommendations in terms of what can be tackled. And so that report would be pulled together by June, and then it will undergo the review process after that point. Anything questions now, or?
One question on the service array assessment. We had a robust conversation over lunch about what qualifies as a service, and that sometimes it's not that a gap exists in a specific service type, but that getting a family and a kid connected to that service in a meaningful and timely way is where the barrier lies. Will the service assessment also look at matching, triaging, referring so that people get into the right service that does exist?
I think that'll ultimately come up in that kind of review process when we summarize the data findings and people get to respond to why something's underutilized or doesn't exist. What will underutilize to the extent that it does exist, or there's not enough of it. So the intent is that there's going to be some sort of stakeholder work groups, focus groups, where the information can be with these types of barriers will come up and get logged, so they can be included in a summary of what's going on, and then related to pulled into recommendations where relevant.
Thank you. I see that Rep Walker is online and she has her hand raised. Rep
Good
Walker.
afternoon, everybody. I'm sorry I'm not there, but I'm enjoying the conversation, and I wish I was at the 12 o'clock, but I'll be the next one. Anyhow, thank you for this outline. And I know everybody who knows me knows my favorite part is the data infrastructure, and then also the governance and financing. Those two seem to go hand in hand to me, and I think this is a part that's going to really be important for us, because we do have so many things going on, and we have great intentions and everything, but I think sometimes we have a lot of stepping over each other or stepping on each other. And I'm hoping that this is going to give us a sort of a backdrop to try and get collaboration and emphasize collaboration, so that we can make milestones that we can measure, because we see so many things that we've been financing and supporting, but they've never really been measured to see if we've made any headway or if we're going in the right direction. And it's not to say that anybody would do it, deliberately. It's just sometimes we get so serious in what we're doing, we kind of get caught up in the mess. And I just hope that this is going to help us do that and collaborate, because there are so many things that are going on in the agencies, and then we have a lot of other organizations that are going on that are all should be going together in the same direction. And I'm hoping that this is going to do it. So thank you for the information presentation. I would like to, I know, but I would like to get some of this stuff earlier than their deadlines, but just to let you know, our session goes from January to June. So if there are some tweaks that we can do, we can't wait until April to tweak it, because that ship is down the river. So, just saying, I know people don't like to understand that this is all part of legislation and policy and development, but it is. And you have to engage our colleagues in these conversations, because they're the ones that have to push that movement in policy. So it would be really good if we could have a lot of these beginning conversations with the expectations of where they might be going and what we might be able to do. We don't have to get every pie that we want, but I mean, what we do have to do is start to set the groundwork for the directions that we'll do in the second year. So Thank you. My 2 cents.
I do want to acknowledge that the one everything you outlined as things you love are things I love too. So thank you for that. Those are my favorite topics too. And we certainly are committed to being present and facilitating conversation to seed readiness for whatever can happen at a timely manner. So I mean that's been a lot of the kind of back and forth with Tower around deadlines and dates. So if you want to have an offline conversation about how we landed there and have some influence over that. I'm assuming you have influenced Erica some in the deadlines as well, but we're here to make sure this isn't going to happen inside innovations and then get dumped on this committee. This is collaborative work, kind of setting the example of how you're calling the state to collaborate. So that's certainly something we want to be part of as well, so that along the way, people have the updates they need, right? It's not a surprise. Yeah.
Madam Chair, may I just respond? I think you're absolutely right. The most important thing, though, is we do it as a collaboration. So I'll do any conversation, but I want the conversation to incorporate everybody so that it adds to the atmosphere of collaboration. So I think in our subcommittees, that's where the meat and potatoes really are going to come in. And so we at that point we can start to really move. But I want all the people that are listening to this and have great ideas to express those ideas in the committee meetings and talk about them so that we can start to formulate a little bit more concretely of what we're going to be doing. And it has to be with everybody. So we want to
call to action. Thank you.
Thank you so much, Rep. Walker, and I totally agree. We definitely want to be transparent and collaborative in nature. I saw another hand raised. Let's see. Okay, Alice.
Thanks, Deborah and Jill. I just have a couple questions. In the document, I know this is where your heart lives, but you don't mention families or you don't call it out. You say, children. And I was just wondering that the reviews were going to include services that also serve our families. And the second, I have two parts to the question. Knowing wraparound in the system of care, thinking a lot about integrating the physical, mental, and social drivers of health in your consideration of any of the reports that you make. So it would be Medicaid services, but also it would involve a lot of the various commissioners, right? All of the DPH, DCF, DMIS, and things like that. So I was just wondering if that was included, or were you going to just stick to the child behavioral health current funding system? Thank you.
So I think those are great questions. I think, when we say children's services, we're primarily thinking about the the recipient in the system. And so Medicaid allows, as you well know, right, billing for services that support the family members on behalf of the youth. And so we're really thinking about those services. So something like peer support would absolutely be part of that, that's provided to a family member, or family therapy, or those things. I don't think at this point in this initial pass, we'd be looking at services that are for just the parent. Like if a parent and child show up and the parent also shows up with mental health needs and they're getting therapy, I don't think we'd be pulling that into this at this point. That might be work for the 2-gen work or something else. But at this point, really focusing on the specific children. So that's what I would say about that. In terms of the drivers of health and on the other components, I do think you have to look at all the commissioners. You have to think about all the funding. When we think about public behavioral health funds, we're talking about not just Medicaid. We're not just talking about DCF. We are talking about public health, DMIS, DSS, whoever else. When we look for the financing review, we'll probably do a narrower look And then the proposal for the behavioral health expenditures report is typically broader, although that would be directed by what TCB asks for, right? But we have done these expenditure reports with communities, with states, where we look at parks and rec budgets, where we look at housing budgets. There's a lot of different ways you can think about who's contributing to kids' behavioral health. How far do you want to go in terms of what prevention looks like and early intervention looks like? How much of, I mean, schools have to be part of that budget for sure. And so I see a question about children with disabilities. And so, when we think about behavioral health and these needs, we think about mental health, substance abuse, substance misuse, and intellectual and developmental disabilities and co-occurring disorders. So that is sort of the collective that we're looking at, with a primary around mental health or mental health with substance use. But wherever there's co-occurring with IDD, that is absolutely part of it. And to the extent that we have data on just IDD services, we would want to incorporate that as well. Because it impacts so many kids and families and the well-being, and it's hard to pull those apart, and we wouldn't necessarily want to. So, putting all of that together, looking at school data, especially funds that are maybe not showing up in the Medicaid system because the schools are paying for them. I know we've had lots of presentations on school-based care in the past couple of meetings. So looking across, you've had ARPA funding, other kinds of fund sources. So where can we pull information? What do we have available, and what goes on the data development agenda, right? We don't want perfect to be enemy of good for this. And so what we're going to do is we're going to work to produce something that feels good enough for smart, informed decisions that reflect best practices nationally and in Connecticut. And then we're going to call out where are our limitations and caveats, and what do we need to do better next time? What data do we need more of? And what questions do we still have? And so that's really what I would say. But Michelle, Jill.
No, that's exactly how I would have answered the question. I am going to call on you. I do want you to mention some of the newer EPSDT guidance that's been coming out of CMS, because it's a new opportunity for states in some ways. So, not to put you on the spot, but I am.
I mean, as folks know, EPSDT is a Medicaid, both a benefit and a program. And under EPSDT, kids under 21 in Medicaid who are Medicaid eligible have access to whatever prevention, treatment, diagnosis, services, whatever they need to treat or ameliorate their condition. It doesn't have to improve. It doesn't have to go away. The standard is set to be higher than what we provide for adults. And the recent state health letter that they call the SHOW that just came out on EPSDT says that multiple times, like the standard for adults is here and the standard for kids is much higher. So this new guidance talks about creative ways that states can be leveraging this EPSDT authority. It is certainly easier said than done, because once you get down to it, you have to figure out all the mechanisms of how do you tell people about it, how do you gain access to it. And so I think what Jill and her team are doing around service assessment will help inform this conversation on EPSDT and maybe answer questions Connecticut might have about, are we being creative and innovative in our use of EPSDT? Do families have access, or are we seeing that families are really only accessing very traditional services, even when we know other services may be available? So we're going to be putting out some guidance ourselves on kind of what the new guidance out of CMS says to help pull it apart. I'll throw the link in the chat too. But really, it just is one more way that it's not that the feds did something new and suddenly, created a new authority, but they're being more clear about the availability of an existing authority as a way for states to leverage federal dollars to support their work.
I think you have to step back and do a little more explanation of EPSDT. Sorry. Based on the text I'm getting.
Yeah. So EPSDT, and I'm holding my my trusty guidance. There's this new 57-page document, but it's the early and periodic screening, diagnostic, and treatment. It's a component of Medicaid, right? And so any child who has Medicaid, if they show up and they need some sort of service, they need treatment, whether it's physical health, mental health, oral health, they're supposed to get it, right? And that's part of why Michelle talked about these lawsuits all over the country. A lot of these Department of Justice lawsuits are EPSDT lawsuits because states are being charged with not adequately fulfilling their responsibilities under EPSDT. And depending on the state's delivery system of how they've structured Medicaid, it can be easier or harder to meet that. And some states have stepped so far away from service provision that they're not even sure what they're providing. I think Connecticut actually is an example of a state that's tried to keep its arms around things in the behavioral health partnership, in the work with Carolyn. That seems to reflect a really hands-on approach. And I know there's challenges with the system, absolutely. And seems to be a better ownership of the system. So I think we can get closer to answering these questions about who's getting access to what and when and how. And I think, so this provision is something that really is an authority that lets states make sure they have a way to provide services and get reimbursed, even if it's a service that isn't set up to normally be provided. It helps meet a unique need, and hopefully when there's enough kids with a need showing up, then the state figures out how to create a code for it and have enough providers panel to provide the service and that kind of thing. So it's meant to address all those things. It also has things like periodicity schedules and expectations of like every child getting a certain amount of well visits and other things like that. So there's expectations that are set, there's minimum requirements that are set. And then there's this just kind of these provisions that say you can do this in a bunch of different ways, depending on the state, depending on the use of managed care, all of those kinds of things. So it's depending on the state and the community, like it's both a benefit and a program. And so that's what gets confusing with it. But what's exciting right now is that the feds have leaned into it and said this is a mechanism by which we can help states do better to support kids and families and gain access through Medicaid. So for Medicaid eligible children and youth and their families. And so that's really, it's a mechanism, just like these other Medicaid authorities. It's just broad.
I would just make note too, that on a biweekly basis, our team puts out a TA telegram, goes to we're up to like 50,000 people across the country. And Deborah does a policy corner, and she'll be breaking down this new guidance from the feds regarding EPSDT over the next few telegrams in our series. And so the effort, because this is, slightly complex and kind of behind the scenes technical, I would just encourage people to sign up and read that. She's going to try and make it as user friendly for the country as possible, and then provide some links and guidance. And we're certainly willing to come back and talk even more about this, especially as we get further along in the service array assessment process and so on, because I think we can link this better for people as to why this expansion and newer guidance could be a true benefit to Connecticut in the efforts you're all trying to undertake to improve the system.
Thank you so much. I think we have a question from the commissioner. Commissioner Hill-Lilly.
Good afternoon, and thank you for this presentation. I thoroughly appreciate and deeply appreciate the holistic approach that's being used to make these assessments. I think these are the right focus areas, and I think you're absolutely right. I have been fortunate enough to spend some time in DC with some folks on the Hill, conversations sort of facilitated by the Brookings Institute. And they're having these very conversations. It's a think tank, and they're really trying to inform what's happening on the Hill. So it's nice to see that we're doing almost like a parallel process here in the state. I had just a couple of questions. So we know that workforce is a challenge everywhere you go. Workforce is it's just an issue. I'm just wondering how deep. It's one thing to assess the needs and to see what data infrastructure is needed, we have, and what services are being delivered. But are we going to be looking deeply into some of these workforce issues? Because it may be that the needs are not being delivered as intended because of the workforce issues. That's question number one. Question number two is, have you done similar, I know you mentioned your national experience in doing some of this. Have you used this particular approach in other jurisdictions? And if you have, what are the potential types of recommendations that could come out of a process like this?
So I think this workforce question is an important one, and I wish it were an easier one to answer, because the challenge that's going to happen is the data are going to reflect access. And so if there are waiting lists, and I know there's like, we've heard from folks, oh, there's not supposed to be waiting lists and certain things and all. So if we have waiting list data, that is an indicator, right? If we see people getting, if there's any data that shows somebody's had an initial visit, but not any follow-up, if when we get to looking maybe over time, looking at expenditures and claims data, that's where we sometimes see things about whether people have gotten a duration of treatment that is sufficient, or if they've only had 1 or 2 sessions with somebody. Those things tend to point to workforce. But the truth is that the workforce questions get answered probably a little bit differently than these mechanisms. One of them is probably the reimbursement conversation that I know folks have been having. And so that will get touched on through a little bit through the financing report. And Jill will touch on workforce a little bit through the service array. But Jill, you're not going to see a lot of that because what our data are going to reflect the current utilization.
Yeah. And through our little work group who's working through the survey design, we're trying to figure out how to integrate workforce, wait lists, the kind of things that are popping up in terms of what the access issues. And we'll have to be a little creative with how we do that. So we're trying to figure out how do we craft it within a structure that's going to be easy to respond to and get quality data that can help people make decisions. So we'll see how much we can tackle within that survey.
I will say though, running parallel to all this, right, is the capacity to look at just who's going to what undergrad and graduate school programs. And so, from the university side of the world, we know that from a population perspective, we've got more people in care because boomers are still in care, right? And less people who are even eligible to go to college or get a master's degree. And so people are leaning a lot into peer models or para models. That's a good conversation to have. It's not necessarily embedded in our to-do list right now, but like there's all the ways Deborah and Jill just talked about how you get to that data. And then there's just kind of some simple mapping that providers have whatever percent lack of staffing, across the country when I work with the CCBHCs, a lot of them throw out like we're only 80% staffed, at any given time. So like there's how much are our people staffed? Who's coming into the pipeline to even take these jobs? And what can we do proactively? So I was just at the National Association of State Mental Health Program Directors conference, and Kentucky stood up and asked the assistant secretary at SAMHSA to consider a different model for loan repayment. So they took on a project where they worked hard to identify funds using some federal funds, some state funds to ensure, because the idea of loan repayment in a lot of these programs, degreed programs, is hard enough as it is, right? So like kids aren't coming into the field because loan repayment feels hard. And so they set up a model where there's no loan repayment. Like you get in, you have commitments on the back end, but they're paying along the way. And if I remember the numbers right, like they put it out, they were looking for, I don't know, like 35 or 40 people. They had like triple the number of applicants. So the point that state was making to SAMHSA was this isn't about necessarily people's interest in coming into the field. This is about cost of education against salary at the end and what kind of burden that puts on people. So that's like one way to tackle it, that one state example puts forth. And then most states are also thinking about really what can be done in peers, through peers, what can be done through paraprofessionals, non-degreed professionals, what can be done by bachelor's level, what can be done master's and PhD level, and getting a little more clarity on who and what and why. to try and really help this issue, because we absolutely, from an academic side, understand the pipeline is the end result of that pipeline is still not going to produce enough students to the need that's out there. So we can do all the things Deborah and Jill talked about, and there still is just a known issue that you could have us do all kinds of analysis, but at the end of the day, there's some creative strategies out there that states have been taking that Connecticut may want to look at. Like DC just stood up through their DC University 30 free MSWs to go through the program on an every 2-year basis. Again, tackling this issue of like loan repayment doesn't always incentivize people to come into the field, whereas upfront scholarship might might really bring more people into the field. And that doesn't have to be MSWs, but I'll own the fact that I'm biased as a social worker.
That's why I was a Title IV student, right? W.
Rep Walker has her hand up.
Yeah, well, I want to answer the second question that got posed, which is, did we address, we've done this in other jurisdictions? And I think, and the answer is absolutely. And depending on the state and community, what people have done with it varies, right? From everything from the work Jill has done with these service array assessments has been able to translate in one state to being part of provider contracts and having better clarity and data tracking ability in terms of capacity, identifying needs, and setting standards for providers. In some of the financing analysis has led us to helping folks write state plan amendments, shift some of the financing for other services, prioritize other services, write grants to then create seed funding for new initiatives. We've seen a lot of that happen too. So some very practical next steps. Sometimes it leads to just very concrete, like mini implementation planning and prioritization. So we might come up with a financing review and have 30 strategies, right? And then the jurisdiction does the work to prioritize what is most important to do first. Sometimes that's tightening up contracts with their managed care companies. Sometimes it's new quality measures that they're going to start implementing, or having implementation teams that include, families and providers and state agencies all together. So it kind of depends on what gets highlighted, but absolutely this leads to very concrete next steps. And the work is just never done, right? And so we're always trying to improve, but we can, depending on which things, we're happy to talk more about that.
You have 2 more
Thank you so much. I have 2 more questions online. Tammy, I'd like to call on you first. I know you've been waiting patiently. Thank you so much. And followed by Rep Walker.
Oh, no problem. At the beginning, when you were talking about this, you said it has to remediate the issue that's going on. And so again, I'm just always going to say the concern is if somebody has ID or autism, they're going to say, well, then they can't be in this program because you can't remediate that, even though there's co-occurring conditions like mental health, behavioral health, those kind of things. I just want to make sure we're not setting up a system where they're going to be excluded, because if you have ID, you're going to have ID. If you have autism, you're going to have autism. So those are just always my concerns, because we're Department of Developmental Services, that's what we do. But I just want to make sure that we're not setting up an exclusion.
No, I think that's great. And we always lean toward inclusion versus exclusion for sure. And what's really great about the new EPSDT guidance, which I'm so sorry, I literally have it in front of me, so I'm going to read it. They call out, which we have in a few places, and this is not new, right? But it's clarifying for the field that the language in the statute talks about correcting or ameliorating, and CMS in this particular letter says that they have clearly interpreted correct or ameliorate does not mean something has to, quote, cure a condition. It can maintain a child's health. It can improve a child's health. It can mean that it prevents it from worsening or from creating additional health problems. So they say explicitly physical and occupational therapy, for example, are covered when they have that maintenance purpose even. So there's more detail on that. So I appreciate you raising it and helping us to be really, really clear that we are looking to be inclusive so that we support all kids and families.
Thank you so much for that. And Rep Walker?
Yes, I promise I'll be brief, and I think we all should be brief because we're getting a little lengthy in this, but I just want to say, please don't hide the fact that workforce is a barrier. Please bring that up because you got to give us that information. We have to be able to have resources to say if access is being limited to families and to kids because of a shortage in the workforce. And it's up to us to put the emphasis on how do we aggressively go out to fill that part. But if we don't have you to give us that resource, we're up the creek because we have no factual, it's all anecdotal. So that's my 2 cents and I'll shut up.
Appreciate it. We want to thank everybody for letting us take this time. I do want to call out that I also recognize that Connecticut had a number of people, probably even on this call, that helped create your workforce strategic plan. And so we'll lift that up as well as things we see from across the country and absolutely take Rep. Walker's guidance about ensuring that's embedded in the documents we provide you guys. So thank you all. I'm sure you'll see a lot of us. I know we're looking forward to seeing a lot of you. So thank you.
Thank you so much. And before we let you go, Senator Marr has something she'd like to say.
It's just in following up on what was said earlier about the cost of social work and how expensive it is to get that degree and the ROI on that. We heard last week, I think it was last week, it's all meshing together, at a pediatrician roundtable that is one reason we're seeing less pediatricians going to that area of practice because the ROI on that for paying off loans is not sufficient. And so as an example, an NYU MSW degree from 2 years ago was $100,000 to get that degree. And the ROI on that is going to take years. So I want us to hold both that thought, which is very important, but also something that came up in our discussion today. We don't want, when we're talking behavioral health, mental health, and crisis and taking care of our families and our children, we don't want to expect a level of training. So how do we hold both of those thoughts at the same time? Because it's really important that we really do train our people to be strong therapists and people who know how to help families and children. But also we've got to look at the cost. The cost is prohibitive. And how do we incentivize that and make it happen? So thank you. I just wanted to comment on that.
Thank you, everybody, and thank you, Michelle, Deborah, Jill, and Lena for your presentation. We will definitely be in touch as we continue the work. Next up, we want to very quickly bring you all up to, again, do some level setting of where we are with, as you heard us mention and you received, as I mentioned earlier today, you in your packet of your monthly TCB meeting was a draft, very much a draft document of the current what's being discussed in the two work groups, infrastructure work group and the services work group, of possible, I keep using the language, possible legislative recommendations. The way in which this process is that through the operationalization of the TCB, we have created work groups where they are identifying areas of priority. They are taking in stakeholder input. They are working that many individuals are invited as stakeholders, nonprofit organizations, state agencies, you name it, legislators, all invited to participate in these work groups. And this is where the work is also being done and diving deeper into the areas that have been identified as gaps, areas to brainstorm on strategies or possible strategies. And in those particular work groups, we are also, once we start to identify those strategies, start to have the conversations about what is needed as a possible legislative action versus maybe it's a policy change that happens within in a state agency or in the field, not necessarily needing legislative action. So that is also weighed into this process that we do. The other thing is that it is very much a vetting process. There is a lot of planning, a lot of conversation, and it's going back up and down from the work group chairs to the work group members, back up to the tri-chairs of the committee, and then again shared out. And so that's where we are now. Right now, we have conceptualized. These are conceptualized some draft language. In front of you, you see a timeline. And even if you see the word final, it's really not final because it's a vetting process. So for example, as of today, we have shared with you the first conceptualized draft of recommendations. We would love your feedback. Everybody, please give us, we want to collect that feedback. Send it on over to the Tau Youth Justice Institute, either myself or Israeli, and we share that. We do not change it. We do not modify that language. Any feedback you give to us, we compile it and give it to the chairs of the work groups, as well as share it with the TCB chairs. Give us that feedback. That feedback goes back to the chairs, as I mentioned. They then review it within the work groups where it stemmed from. Then that goes, if modifications are made to this particular language that you're seeing in front of you today, those are made in a consensus. Not everything is 100% agreed. It's really hard to find that kind of a space, but it's in a consensus building. And so, that it goes back and forth. That language gets massaged even more. Then it's brought back to you all in November for another review, and again so you can get the chairs as well as the larger stakeholders get a temperature check. Where are we headed? What changes did we make to the language? And all of that to say that our hope is that we have some solidified language that we all can feel comfortable with, that can be brought to this committee for January to be adopted and voted on as the possible legislative language. Now, what happens to that package after it's approved in January is that we give it to the TCB chairs, and then the legislative process take place. And there again, there's even more opportunity for public comment and so forth. So I just wanted to share with you all this process, which for myself, at least my experience, has been a pretty effective process where we are taking input from a lot of people. We are doing this in a collaborative way. And again, with the hopes that it can lead into some kind of action that improves the system. We've seen this happen. I know Representative Tony Walker is on the call. We've seen this happen at the JJPOC, the Juvenile Justice Policy and Oversight Committee, who's celebrating their 10 years tomorrow. 10 years of legislative work and reform. And that was through the same process that we are doing today. We've instituted that same process here. So I feel very confident in that process, but open to changes, but feel confident. So with that being said, I would love to give the floor to your co-chairs of the work groups who can present in the conceptual language that you see before you. I'm going to give the floor first to Alice Forrester and Jason Lang, who are your co-chairs for the infrastructure work group.
Thank you, Erica, and thank you for the opportunity. You have the language in front of you, and I don't want to read it, verbatim, but I think I'm going to present the first recommendation, and Jason will do the second. The first recommendation that the group is pretty coherently agreed upon was not consensus. I think it was universal. Is really around strengthening the workforce / reimbursement rates. And I know Tony Walker had said, not waiting too long because the legislative session's going in, and that we were citing the the study that was done, the Medicaid Part 1 study that was done recently published, and that it is showing Connecticut comparably around 62% below our 5-state comparison. A lot of folks don't like a 5-state comparison study, but I know that the work that UConn is going to do will actually also contribute to some of this knowledge. We are talking about a 42 or in 2024, $25, somewhere around a $45 million investment. And again, we have folks in our committee that said that's a breathless number. But we did talk about the numbers that are going around right now in terms of, you know, the guardrail conversation as well as other areas. And comparatively, 45 million is not, we don't think, an reasonable number. We will be showing you in our next meeting some documentation of agencies across the state and in particular around their outpatient services and how much they lose per unit of service, with very complete detail of both the administrative and the cost burden that is happening and how many agencies are actually trying to make up for that loss through various programming and fundraising and things like that. But we are at agreed that we are at a crossroads right now with COVID ending and with ARPA dollars ending. The group was very clear that this was the number one recommendation that we wanted to make. In addition to the recommendation, the data and the understanding that even legislation, this last legislative session added $7 million to the Medicaid payment structure, but the and we thought it was going to be about a 6% increase, but in general, it was really it was laid out differently, and it really only wound up to be about a 3.65% increase across all of our different behavioral health codes, which are limited right now. So, you know, I think that it's important to pay attention to that. The lack of adequate funding, which really runs somewhere significantly well over $50 to $60 a unit of service, causes us not to have enough dollars to be able to hire a more experienced workforce. And then the question of the workforce certainly comes up for us. We did talk about the Horizons program and how well that's doing actually right now, where there is scholarship and hiring social workers from Southern and nursing programs is working very well actually, in terms of incentivizing local community folks to become social workers. We are recommending that we look at a billing code or modifier to enhance the rates for an enhanced care for evidence-based practices. That's a typical and normal thing that happens across the country. That is a recommendation we have laid out in recommendation 1B. And we are looking at the Medicaid reimbursement to be evaluated not just this one time, but to have a process ongoing that looks at the cost of care as rates go up. We are asking the Department of Insurance to pay attention to incentivizing commercial insurances to match the expected increase of Medicaid rates. We did get testimony from Dr. Giffords' group on the looking at commercial rates and Medicaid rates, and there was confirmation that the commercial rates are looking very closely at the Medicaid rates and are staying somewhere below what the current Medicaid rate is. So, you know, if we're looking at a $60 loss for a unit of service on Medicaid, we're looking at close to a $80 or $100 loss on commercial insurances. And so really paying attention to that. Also, making sure that the Department of Insurance should prohibit insurers from us really exchanging information about our rates and reimbursement rates. I can't talk to Tammy about what her rates are at Village for Anthem. That's not allowed. I don't know if that's something in Connecticut can be lifted so that we could have a much clearer and transparent understanding of what commercial rates are looking like in the state. And we are absolutely, as everyone said today, looking for high quality care. But we want everyone to realize that the rates that we are talking about include not just the unit of service and the one person developing it, but all of the different trainings that we have to do for our staff and supervision that we give and all of the administrative tasks and the data and the quality assurance, all of those things are very, very costly, in particular for licensed agencies where we're looking to maintain our license and maintain status. The administrative burden is quite high. So I don't know, Jason, did I do okay with that? Anybody else on the committee?
I think you did great. Yeah, I would just emphasize that it really was tying to the workforce issues that we heard about already today, and that in order to attract and retain, a skilled, qualified workforce, we have to be able to pay them, enough to make it worth their while. And so the reimbursement rate is really, I think, the only way to really get there. You want me to go into the next one? Okay. All right. So I guess we'll take questions and comments after. So I'm going to talk about the second recommendation from the infrastructure work group. This one is around data, and it really came out of the idea that the TCB is here to improve the children's behavioral health system. And in order to do that, we need to know a little bit about how the system is working, whom it's serving, how well it's serving them, what the wait lists are, what the quality of service is, whether there are disparities in services for certain populations, and how effective the service array is. And so sometimes, we make changes or we hear anecdotes about things, and that's I think a risky way to make big changes and decisions about the system. And so our group really focused on what data is necessary or helpful or important in order to support our understanding of how well the system is functioning. And we thought it was important for accountability, transparency, to know where services are available, who they're available for, and where the gaps and needs were, so that we could better identify resources to fill those gaps and needs. The work group was really also very clear that this recommendation around data was dependent on the first recommendation about reimbursement rates, and that it wasn't really going to work to ask anybody to collect or enter more data if we're not addressing the underlying fundamental issue with the cost of service delivery and reimbursement. So that's why this was our number 2 recommendation. We heard from Innovations that they are looking at some of the data on children's behavioral health. So our work group kind of has been doing this in parallel with what they're doing. And we recognize that some of the recommendations that come out of this work group will be informed by what Innovations reports and recommends as well. But a couple of the ideas that have come out, and again, all the details are in the packet, are looking at the existing data that's already collected. We've heard that there is a lot of data out there, a lot of data that's required or collected, but not all of it is publicly reported or even reported or aggregated or analyzed at all. And so we want to make sure we understand that. We also need to understand where the gaps in data are. So there are lots of services and providers where there's no data at all, and we don't know anything about those services. The group talked about ultimately having some type of public dashboard that would begin to get at all of these issues. So service availability by region, community, city, eligibility for different services, those that have eligibility criteria, the capacity of those services, whether there are wait lists or not, something that the public and people who refer children for mental health services could go to see what's available, whether there's wait lists and if they're appropriate. And we also talked a bit about the importance of having data on the quality of services and the outcomes, how effective services are. And it's just the research shows that overall, based on national studies, about half of mental health services aren't significantly clinically effective. So we need to do a better job to understand, which ones are and where we can make improvements. And then part of the data conversation continued to be, how can we reduce and minimize the data burden on providers, recognizing there already are a lot of things that they're asked to collect by different governing bodies, entities, state agencies. Some of it may not be necessary, and there seem to be ways to be able to streamline that rather than just adding more. I'll stop there, Alice, if you have anything to add, and then otherwise we can go on.
No, I think that services group will reiterate our, at least our first recommendation. So thank you.
Thank you. And I'm going to pass it to my colleague Edith, actually, for the service array. Just wanted to say for the first part that our recommendations in the service array are identical to the recommendations in the structural work group, because regardless of service availability, without workforce amelioration and reimbursement, we're not going to get very far. The other thing I wanted to clarify, it's not all about workforce shortage. This is a problem that's existed well before the pandemic. We've been deficit funding for a very long time. I can't remember the last time there was not deficit funding. It just got worse with the pandemic, lack of COLA, inflation, workforce shortage everywhere, people moving into telehealth. But we have been paying to see people. I joke that we love helping people so much, we pay to see them. And we've been doing that for probably 2 decades. It's just becoming a crisis point, which is how some of the in-home services close throughout the state. So it's really not, the story is not pandemic, workforce shortage. How do we shore up the workforce shortage? It's really tied into the larger reimbursement issue at this point. So I wanted to just highlight that point. So our first recommendation, like I said, likewise joins with the structural work group recommendations. And then we have separate recommendations that UConn Innovations already spoke largely about, but Edith Boy will share that portion of it. Thank you.
Thank you, Jan. Before we move on to the second recommendation, because yes, there's alignment with our first recommendation, the services work group and the infrastructure work group. But I think something we don't talk enough about is the harm that the workforce issue is causing our kids. 53% of the children screened at LifeBridge for trauma last year experienced 6 or more traumatic events. They get placed with a clinician. The clinician's there however many months, oftentimes not even a year, and then they go work elsewhere because non-Medicaid providers, there's lower acuity. The cases are easier, let's face it. And these are heavy, heavy cases, and they're paid more. So I just want to point that out. And it is not good for a child to have this turnaround with the clinicians that they are seeing. So I just want to point that out. Jill did cover the services array assessment, so I won't go into a ton of detail. I do want to thank our work group members for their participation and their commitment. It's very, very helpful. For those of you who have are really vested or interested in informing the design of that survey for providers, there's still time to join the subgroup. We're in the midst of designing this survey, and it's one of those things where you want to be comprehensive enough, but not make the survey so cumbersome where providers won't complete it. And in terms of data integrity, we also want to make sure we're comparing apples to apples, so providing definitions so that providers are reporting the data appropriately. So there's a lot of thought that goes into this survey development, and we're going to try to get it as right as we possibly can. But please do let Erica and Israeli know if you would like to join the subgroup to help inform the design of the survey. That's it. Open up for questions. I would just like to say, before we take questions, thank you so much to our work group chairs for all of your hard work and for all the individuals who are participating, because we really do need this information. I think we're seeing some common areas, not necessarily big surprises, but it's still really important to dig in deep and to really consider this, and also know we're taking recommendations, and this is, as I want to keep reiterating, very early draft form, and we're looking for input. That said, are there any questions? Yes, Dr. Powers. Yes, that's fine.
Just trying to behave today. Thank you. The one question I have is the emphasis appears to be on publicly funded services. And that's great. And I'm thinking though about what happens here with a state that has an awful lot of private providers. And we have I speak with an entirely unscientific assessment, but from being boots on the ground for 33 years here, there are far more kids with Husky than there are people who for intellectual developmental, neurodevelopmental disabilities than there are providers for that. There are far more private providers for that group of individuals. And if this population of private providers isn't part of the assessment, the service array is going to be skewed. It's like you only look where the flashlight is shining. And so my concern is, and there may be great reasons to, fiscal reasons or, just resource reasons to not look at that group. But I think it's a very different situation here in Connecticut than you'd have, for example, in Wyoming, where you don't have a large population of private providers providing services, and Medicaid services are the main pot of funds. So my concern is that in leaving them out, we're not going to have a full view that would inform some of the decision making that might go on, and also perhaps a lever to pull to push the private commercial insurance to be able to be more responsive. And they're very responsive in Connecticut. We have one of the best, for example, autism insurance bills in the country. But there's certainly a group of kids that are still not getting served. And they have private insurance because we don't have enough, as you guys have talked about, workforce support. So I just bring that up because if there's a consideration about widening the view, I think we will have a better assessment of services that we have available that may not be captured if it's only publicly funded.
Thank you, Dr. Powers. Edith.
Yeah, in response to that, we did discuss it in the work group. And what's tricky about private providers, as you know, is identifying them. And that doesn't mean there won't be another phase of this survey distribution to that group. And we definitely discussed it. It's just this first phase felt with the timeline that we were given that it was achievable. Jill's on the call, I think still. She might have more to add.
I think Deborah's jumping in.
When we all work together this many years, we all jump in together. I think that that's exactly right about the timeline and where do you start. I think we tend to recommend states focus on the publicly financed first because those are the levers they can most easily pull, and then use those to look to parity issues, look to opportunities like we see in some other states where certain services are required to be covered by commercial insurance. And so if we can focus on getting the Medicaid and other publicly funded behavioral health services kind of right-sized and financed appropriately, then this creates an opportunity to think about, are there things that need to be done to create Medicaid lookalike numbers? And my understanding is there actually is at least one service in Connecticut where kids with private insurance can get access to that service using essentially Medicaid lookalike number. New Jersey has a whole system of that. Massachusetts has a new service, a mobile crisis service that's required to be covered by commercial insurance. So there's lots of examples you can look to. And so I think Edith is exactly right, though, why we focus on the timeline, what is in the purview of the agencies here, what can you actually control and move forward faster while not losing sight at all of the importance of serving the entire population of the state of Connecticut. Michelle or Jill, did I miss anything we would note in that? Okay.
No, I just do want to emphasize that we fully appreciate the amount of private insurance that is funding kids' health and behavioral health services in Connecticut. So in no way is this a sidestep. It's really about, like, if we tried to pull that, to reiterate, Deborah, if we tried to pull the levers at the same time, you'd be sitting longer to line up for Medicaid and private insurance. So that's why we do this, right? Let's do what we can faster and take on the other in a methodical way that we get the right data to make good interpretation.
With the opportunity to look at your benchmark plan and things like that too. So there's a few different places in policy that could be looked at. And
Yeah.
I think some of the work group recommendations start touching on some of those elements too.
Thank you so much for that. And I do like the idea of this is 1A, but to look at the private provider side as a 1B, it's incredibly important that we look at that element of the population. So thank you, Dr. Powers. And Jan has a comment.
Yeah, thank you. And Dr. Powers, just to clarify, and for this is a Yukon to a clarification question, because the survey will include folks that that are private used or provide services through private insurance as well. They just happen to do Medicaid, so it's not Medicaid exclusive focus here. But you seem to be talking, Dr. Powers, about those private folks, individuals who exclusively deliver through private insurance.
I hadn't split that hair, but that's an important one to split. And there's self-pay in here too, because from my networking, the organizations that will accept Medicaid that are private are often doing both Medicaid, private pay, and commercial insurance, but they are managing their clients' participation, because they can't survive on Medicaid alone. Okay, so there has to be, there are balances that are trying to be achieved just for fiscal responsibility. If the survey is going to capture, for example, my organization is a Medicaid provider. All right, if I'm going to get this survey, that's great, because we will then be able to identify various aspects in this service delivery array. So I didn't know that, and I didn't understand it from the presentation, but now I do, Jan. So thank you. That's good.
Kristen, I'm sorry, Representative McCarty-Day.
Thank you very much. Thank you, Madam Chair. Thank you to all of you for the work that you've done on this and the work you're doing every day. Wearing my former Planning and Development Committee Chair hat, and now with my Public Health Co-Chair hat, when I think about the second recommendations in each of these, I think about GIS mapping. And is there a way that we can perhaps enhance and expand the role of our GIS office that is kind of a nascent budding group, really originally focused more on broadband access, but this is just something that I bring to the table thinking about ESRI, and we were recently attended Rep. Exum, and I believe Senator Meyer may have been there as well. The Council of State Governments had some folks who came in to present for us about this. So just putting that out there for consideration as we continue this conversation. And I am reaching out to them, and we'll be forwarding information to our leaders on that so that you can access that as well.
Thank you. That's a very interesting idea. Thank you so much. That could be a super useful tool. Yes, I'm sorry. Carrie.
Hi, good
Carrie.
afternoon. Just to go back to Jason's recommendation and then related to Edith's comment, I just wanted to remind the council that under the partnership, we do have a significant amount of data related to the Medicaid network. And we had a great meeting last week with the Innovations Institute to start talking about that, how at Caroline we can support the work that they're doing, and are happy to, do that with the committee, the council. We do also survey the private practitioners under Medicaid several times a year to try to keep our network as up to date as possible. So Edith, we could talk about that offline if that would be helpful. I don't know that the survey will be exact, but if it would be, beneficial for the committee to see.
Thank you. Just a couple umbrella comments on the recommendations. And Erica, thanks again for making the announcement. This is really part of the first phase of initiating a conversation, a robust conversation for back and forth. This is how we'll get to more refined ideas and point to some of the priorities that really are actionable in the legislative session. In terms of my first comment is about structure of just generally both sets of recommendations. I think it would be really impactful if we could tease out under each recommendation a policy idea and a budget idea. That's sort of how, when we build the budget out, we sort of look at it from the perspective of what's the language and what's the policy principles behind what we're doing, and then what's the funding mechanism. So I think as we structure it, I think that would be helpful for this group to do with our recommendations. Two, also related to that, I think it's important to know any progress to date in any current activities. We always want to be looking to redirect energy on scaling up something that may have already been started. We got some great presentations, for example, on some of the work that local school districts are doing, including ESS. And so, pointing to scaling those things that may be coming to an end as ARPA dollars and ESSER dollars run out, I think would be a good thing, including Medicaid, the investments we've made in Medicaid so far, and what's next ahead with phase 2 of the rate study. The other piece, as we think of structure, is we need to be mindful of what level of government and what policy lever is the right action. So we could be thinking about it is it as simple as signing a contract and getting a contractor to do some mapping for us? Is it an executive action, a state plan amendment through Medicaid? Is it a legislative proposal where we need legislative action? And then finally, what's the right level of government? And I want to really caution this because unlike some spaces of state government where we have plenary authority to pass laws, in the healthcare space, given insurance and some of our work on Medicaid being a federally funded and state program, we're restricted somewhat by waiver authorities. So we need to be mindful of which actions can be done at the state level and which can be done or have to be done at the federal level. And in particular, we heard from some of the insurance providers when they presented that about 76% of all insurance plans in Connecticut are self-insured ERISA plans. So they would be primarily regulated by federal law. So we always want to be mindful of what are the federal parameters that we're working with in this space, and is the federal actor the more appropriate for some of the recommendations. So that's just some feedback overall. And I do want to appreciate, I know that it's a ton of work to take the huge body of portfolio that is children's behavioral health and try to synthesize all the fantastic presentations we had into something forward-looking and tangible. I think it's important that this group, we were founded as taking care of business, and I think giving people a sense of their own power to make change and to constantly make progress is critical to our success. That success will feed more success. So I appreciate that you guys really drilled down to some concrete ideas, and with the refinement process underway for the next few months, I think I look forward to more conversation. Thank you.
Are there any other questions? If not, I will turn that over to Erica. Okay.
Thank you so much. And yes, we're taking a lot of notes. We will rewatch the meeting and make sure to structure. There is a report that's associated to this recommendations. Anytime we put recommendations, we also do justification for. And so some of that justification goes into those areas that you discussed. And we will work with the work group co-chairs to get that initial draft out to everybody. With that being said, the last thing I want to say is there's just one quick housekeeping. You heard about work groups. So there is, as Edith and Jan mentioned, there is a subgroup. Please reach out to us. They are the ones that are currently in the phase of designing the service gaps analysis. And so that will be implemented in January. So we are looking for more voices at that table to help to design it. Also, there are two new work groups that we want to activate sometime in the new year. That is the school-based work group. As you recall, we had 3 presentations at 3 different levels, from school representations, superintendents, principals, and school social workers and so forth, to the nonprofit sector, to then the State Department of Ed coming, and DSS last month presenting on school-based behavioral health. So we would like to activate that work group. We are still looking for co-chairs for that. We had 1 interview, but we are needing more. And then the other one is the prevention work group. Again, we're looking for co-chairs for that. And so if anybody is interested in being considered as co-chairs for those work groups with our support, you will receive our support. You're not alone. And our current work group chairs can attest to that. That is our role, is to help to facilitate all of these work groups. So, so please reach out to us. In the sense of, if you're interested, there's the QR code, scan that. And then the last thing I would say is that as housekeeping, our next meeting, again, we're sort of out of sync right now just because of holidays and then election and so forth. So our next November meeting is November 13th. There we are, we did some activity today regarding purpose statements and ranking some strategies for or objectives for the strategic plan. We do plan to engage you again, but this time we're going to send you materials ahead of time to make it a little bit more of a smoother process. Lessons learned to make it a smoother process when we engage you in the strategic planning, continuing to plan for that. And so stay tuned for more information around that, another work and lunch. And then followed by the TCB meeting from 2 to 4 on November 13th. Okay, oh, go ahead.
Erica, thank you. Just a quick question. I think early on when we were deciding on the work groups, knowing that we couldn't make everyone a full member of TCB or it would get completely unwieldy, that we were willing to entertain, especially in the school one where maybe there's not a lot of school districts represented, that even if you're not a member of TCB, if there's interested stakeholders and partners, can they also reach out to you to be part of the group?
Actually, all work groups are the goal there is to have stakeholders that are not necessarily even part of the membership of the work group. We want members, but we want to and a further outreach beyond that. So absolutely. Yes. Anything else? Okay, that is it.
No, I was just going to say thank you, everyone. And look at that, 10 minutes early. Whew.
They gave us extra time over there, so they gave us